Hello everyone. Today let's discuss breast conservation therapy. Dr. Geoffrey Keynes was the first surgeon to introduce breast conservation surgery. He performed lumpectomy and implanted radon seeds and achieved 77% 5-year survival in node-negative patients and 36% 5-year survival in node-positive patients. In the late 1950s, the National Surgical Adjuvant Breast and Bowel Project was established in the USA, primarily to clear the many issues and controversies regarding breast cancer. Between 1950s to 1970s, total mastectomy was considered to be the popular and successful option to breast conservation. The NSABP B6 trial, a prospective, multi-center, randomized trial, recruited 2,163 women with stage 1 and 2 breast cancer between 1971 to 1974 in 34 NSABP member sites in the USA and Canada, and published its results in 2002 after up to 20 years of follow-up. The aim was to compare the lumpectomy plus axillary clearance, lumpectomy plus axillary clearance plus radiation, and total mastectomy and axillary clearance. During the same time, a similar trial conducted in Milan, Italy, compared radical mastectomy with breast conservation involving 701 patients with stage 1 cancer. These two trials and several other trials around the world drew below two conclusions. First is, there is no long-term survival benefit of performing total mastectomy over breast conservation, which is lumpectomy, axillary treatment, and radiation. Second is, there was no significant difference in local recurrences between total mastectomy and breast conservation. Currently, in many developed countries, more than 70% of operable breast cancers receive breast conservation rather than mastectomy, whereas in a lot of developing countries, more than 80% of such patients undergo mastectomy. It is highly likely the surgeons performing mastectomies in developing countries are fully aware of the cosmetic superiority of breast conservation and the statistical equivalent survival and recurrence rates in both breast conservation and total mastectomy. Therefore, we believe 4 factors are in operation that lead to high mastectomy rates in these countries. First one is that in developing countries, patients often present with large tumor sizes. Second is the inability to cater a massive patient load because of limited radiotherapy facilities. Third one is the conservative attitude of the surgeons due to lack of peer pressure from surgical colleagues and problems in contacting patients after primary operation, because there is possibility of patients defaulting further treatment. India is a very good example. The high caseload, marked ethnic and language variation probably for every 100 to 200 kilometers offers a significant challenge to the Indian surgeons who are reputedly highly skilled operators. Fourth one being poor patient education. For example, when patients are told that a reoperation may be necessary in the case of breast conservation, many people tend to think that breast conservation fails to remove the tumor completely. Breast conservation has its own drawbacks. First of these is reoperation due to residual disease. For example, a recent study in New South Wales, Australia has shown in about 30% of patients, reoperation was needed within 3 months after primary surgery. This is a big psychosocial burden on the patients even in a developed country like Australia. Then imagine the situation in poorer countries where are 1 or 2 surgeons and pathologists catering for probably 1 or 2 million of the population. Second problem is, in countries where there is limited access to treatment, recurrences may be detected pretty late, which may reduce the survival rates drastically. Therefore, you select breast conservation over mastectomy considering all these factors into account. My advice is to perform breast conservation surgery only when you are quite certain that residual disease and recurrences are likely to be minimal. This is why surgical wisdom is far more important than a bunch of data. Now let's talk about how to perform breast conservation. It is ideal to mark the extent of the tumor on the morning of the operation by ultrasound examination. The incision we recommend is a curvilinear one, incorporating a skin island around the true-cut biopsy site. Such an incision can be easily incorporated to a mastectomy incision if needed. Skin flaps are raised right around over the region containing the tumor, and wide local excision is performed using finger palpation as a guide as shown. The maximum amount of breast that can be removed must be the size of a quadrant. If a tumor needs removal of breast tissue larger than a quadrant for negative margins, it is a tumor that warrants a mastectomy. We always try to achieve more than 5 mm of negative margin right around the tumor. But current evidence say that negative margins of more than 2 mm is more than adequate. For upper outer quadrant tumors, the axilla can be reached through the same curvilinear incision. But in lesions of other quadrants, a separate transaxillary curvilinear incision can be used to access the axilla. If no clinical or radiological evidence of metastatic lymphadenopathy, we perform sentinel node biopsy. And if not, standard level 2 axillary dissection is done. There are 2 aims of breast conservation. First is achieving locoregional control equal to total mastectomy. Second is achieving an acceptable cosmetic result. Breast conservation consists of 3 components. First is wide local excision plus or minus a cosmetic repair. Second is axillary treatment. The third component is breast irradiation, which may be delayed if adjuvant chemotherapy is needed. Here is a list of contraindications to breast conservation. Tumor size more than 4 cm, which are not attached to the skin or attached to the deep structures. Lesions immediately deep to the nipple areolar complex. Multicentric disease. Multifocal disease of more than 2 foci or foci apart more than 2 cm. Contraindication to radiotherapy. More than 2 cm tumors in a small breast hindering cosmesis. And when there is high probability of a BRCA mutation. Close the breast wound after closing the axillary wound, thus allowing to reassure that 100% hemostasis is achieved in the breast defect, since we usually do not insert a drain. This allows the defect to be filled with a seroma. For small defects, no approximation of fat is needed, but larger defects need a rotational breast flap as shown. Dear budding surgeons, breast conservation has saved the dignity and the self-confidence of women with breast cancer all over the world. But do not perform breast conservation at the expense of precious life. Therefore, choose your patients wisely. Think about the nature of the tumor, not only its size. The socioeconomic status of the patient and access to specialist oncological care before you commit. Thank you for watching.